of this lecture.
Thank you.
You're welcome. You're welcome. Happy Respiratory Care Week. I wish I could give these out, giveaways, freebies every week, but save it for Respiratory Care Week. So in part one, we talked about different types of aerosol delivery devices. Name one of them.
Inhaler.
Be more specific.
Ultrasonic.
DPI. Okay, I've heard that one. DPI, dry powder inhaler.
Meter dose inhaler.
Meter dose inhaler. The twist thing is a DPI. Okay.
Unit dose.
Okay, so DPI, MDI, Respimat. Respimat. Those are the three aerosol generating devices we talked about from part one. Now I do know under the DPI category, there's a big laundry list. What? Flexhaler, Twisthaler, Dischaler, Discus, Handyhaler, thank you, Handyhaler, Podhaler, Tudorza Press Air, thank you. I just got to give me a couple first initials of the word. All those different examples of DPIs. Now, this Friday we do have a lab, and this Friday you will see almost all of those variety of DPIs. But what's unique about a DPI? What must my patient be able to generate for a DPI to work? A big, I like deep breath, but I'm looking for inspiratory speed, inspiratory flow. Rapid inspiratory flow. At approximately what liter flow? 40 to 60 liters a minute. If a patient's not able to generate that amount of flow, there's no way they're going to be able to generate the powder to be in an aerosolized form. Meter dose inhaler, what causes the spray to go out? By the patient depressing that button. Now what's the drawback of a meter dose inhaler? Trying to coordinate, get the timing down. When are they supposed to depress the inhaler? When are they supposed to actually inhale? You know, if, for example, if I spray the inhaler right now, and then I inhale, well, we know most of that spray is going to just hit the back of my throat, right? And not actually reach the lung. So, of the different types of inhalers that we just mentioned, MDI requires the most coordination from the patient as well as the device to activate it just perfectly. Now, we help them with the meter dose inhaler overcome some of that coordination thing with what's that thing that we put between the inhaler and the patient's mouth? A spacer, also known as a holding chamber. Spacer, holding chamber, I kind of group those together as one. Many times we'll just call them, oh, it's a spacer, even though I guess technically it's a holding chamber with one-way valves.
That bottle thing.
Say that again? Say that again? I missed it.
That bottle thing.
The bottle thing. Yeah, the bottle thing. If I empty my water and stick the inhaler on the end, yeah, I've just created a spacer. All right, so this next part, part two, is all about the nebulizers. Okay, nebulizers. And yes, there's different type of nebulizers than just one standard basic type. So 3 main categories. The pneumatic jet nebulizer. Pneumatic means what? When you see the word pneumatic, gas powered. So a gas is powering that nebulizer. An ultrasonic nebulizer, vibrating mesh nebulizers, both of these are electronic. It does require some sort of electrical energy to activate those. Additionally, with nebulizers, we can group them and call them SVNs, which stands for small volume nebulizer, or the large volume nebulizers that we mentioned previously with bland aerosol therapy. The large volume nebulizers I'm going to discuss today are actually medicated, where there's medication actually in that large volume nebulizer and not just sterile water for bland aerosol delivery. All right, so pneumatic jet nebulizers, again, require some sort of gas source, compressed gas source. Now there's 3 primary ways we can get that pneumatic gas source. One of them, maybe by a portable compressor. That could be used in the home. Plugged into electricity, creating enough energy to power the nebulizer. Another one could be compressed gas cylinders. So we can connect our nebulizer to a gas cylinder, and the gas that's in that cylinder can power the nebulizer. Or what we would see most of the time in a hospital setting, the wall outlets, the compressed gas source that's there behind the wall. Now, remember this, when we're giving medicated nebulizer therapy, nowhere is it written that we have to run the nebulizer with oxygen. Okay, so I don't necessarily have to run it with oxygen. Right next to the oxygen flow meter, there's an airflow meter. I could use that just as well to power my nebulizer. Okay, so when we give medicated aerosol through a nebulizer, what are we delivering? That medication. This is not an oxygen therapy treatment where I have to be plugged into oxygen. Many times I could just plug it into regular room air, and again, I just need the compressed gas source to power the nebulizer. So be mindful of that. Now, if my patient already has low oxygen levels, then what should they be receiving? What should they be on if their oxygen saturations are low or oxygen levels are low? They should already be on oxygen therapy of some sort, whether that's a nasal cannula or a mask or something along those lines. So if that's the case, I probably don't want to really mess with their oxygen device. If it's working, why mess with it? Why take it off of them in a situation like that? So a patient's wearing their nasal cannula at whatever their liter flow is, and that's working for them. No reason for me to take that off of them and connect my nebulizer to this. I can simply say, okay, I'm going to leave that alone. I'm going to leave the liter flow alone. It's fine running at that current liter flow, and I'm just going to run your nebulizer through regular room air. Here's another thing our students sometimes encounter clinically. You walk into a room to give a breathing treatment, nebulizer treatment. The patient didn't happen to have an airflow meter in the room, all they had was oxygen. And you went ahead and decided, well, they're wearing their nasal cannula at whatever liter flow, but I need to use that flow meter to power the nebulizer. Okay, I understand, I get it. And so you take their nasal cannula tubing off, you connect your nebulizer tubing to it, running it at the appropriate liter flow that we're going to talk about in just a minute. When the treatment's finished, and you disconnect the nebulizer and you reconnect the patient's nasal cannula, and this happens all the time.
You don't adjust the bag.
What liter flow was it on before? And you come out and ask me or one of your clinical instructors, and then we're going to go, I don't know, what was it on before you started changing it? I didn't pay attention. Well, shouldn't you pay attention before you start adjusting this liter flow? So be careful. If you're going to use this oxygen flow meter, which I'm not saying you can't, but if you're using this oxygen flow meter and you disconnect their nasal cannula, you may want to make a note before you start messing with things, and maybe jot a note down yourself. The patient's wearing a nasal cannula at 2 liters, 3 liters, 4, whatever the case may be. Jot it down so you remember. Now you need to power the nebulizer. You need to increase the liter flow higher. That's fine. You finish your nebulizer. Now you turn it off and disconnect it. You reconnect their nasal cannula. Okay, I did jot down. They were on 2 liters before we started. So you can remember that. Because I can tell you how many times over the years students will go in, they get fired up because you're ready to start that breathing treatment. I'm getting it. It's working. It's great. The patient's doing what I'm asking them to do. And now when you're trying to wrap things up and put things back as you found them, you're like, I don't know. I didn't pay attention to the liter flow. So make sure you pay attention. All right, so things that can affect a nebulizer's performance. The first one here, nebulizer design. We're going to talk about the different designs of nebulizers in just a second, so just bear with me on that one. Flow. The flow, now I don't mean the patient's inspiratory flow, I mean the flow from the flow meter. Whether it's the flow meter setting, whether it's the oxygen or air tank you're turning on, what flow does it need to be set at? Well, the higher the flow, the smaller the particle size, small decrease or lower treatment time. Inverse relationship. So think about it. If you increase the flow really, really high, that should mean treatment time is going to go down, as opposed to if you have the flow being very, very slow, that's going to extend treatment time. So again, there's going to be a happy median that we will find, but understand the flow rate going through that flow meter, going through that nebulizer, can affect particle size and can affect treatment time. Now, Typical flows anywhere from 6 to 8 liters a minute. That's what I mean. Your patient could have been on a 2-liter cannula. You're going to use that same oxygen flow meter to power your nebulizer, and you know you're going to have to increase it to 6 to 8 liters a minute. When it's finished, you're not going to leave the poor patient on a nasal cannula at 6 to 8 liters a minute. It's going to start coming out their ears. It's going to be so high. You need to make sure you know what to put them back to. Now, I will say 6 to 8 is typical. Most commonly, that's going to be the flows you're going to see. But I could see times where the flow could be a little bit different than that. Generally not less than that, because you usually need a decent amount of flow to power the nebulizer. But sometimes it's not unheard of to see a flow of maybe 10 liters. But I will defer and say, well, whatever that manufacturer of that nebulizer says their nebulizer needs to be run at, well, then by all means we'll run it at the flow recommended. But 6 to 8 is kind of typical. Gas source. Whether we're using the gas source from a hospital, the flow meter from the wall outlet, or someone in the home, okay? Those compressors in the home do not run at as high of a pressure as what we see in the hospital. In the hospital, what's the pressure coming out of that wall outlet? 50 psi, 50 pounds per square inch. A home compressor, and you can hear it too. You'll see this on Friday. When we plug in a home compressor and you hear it kind of humming, doing its thing, you can tell right away that does not have the same energy or same power that the gas source coming out of the wall outlet is going to have. Okay, so someone in the home, and I would always recommend this, the nebulizers that we use in the hospital might not necessarily be the same ones that should be used in the home. It may look like the one you use at home. It may have the same parts and pieces, patient, for the one that you use at home. But I would say the one you want to use with your home compressor is whatever is recommended from the manufacturer for that compressor. We see all kinds of different nebulizers we use in the hospital setting, and that's fine. 50 psi coming out of the wall is more than enough to power that. But if the patient was to take one of those nebulizers home with them, I cannot guarantee, I'm not saying they can't, but I can't guarantee that that nebulizer would work appropriately with a patient's home compressor, because the home compressor could be only 10 psi. Gas density. Now, oxygen or air is the typical gas we use to power a nebulizer. And like I said, it doesn't matter. We need a compressed gas source. It doesn't matter if it's air or oxygen. I would say this, however. If it's our patients who I worry about oxygen toxicity or giving them too much oxygen, you know who I'm talking about, right? COPD, thank you. COPD patients who, if I give them too much oxygen, I can knock out their drive to breathe. Have you guys talked about that already? Those patients especially, I'm going to make sure I'm running their treatment with air and not trying to give them too much oxygen. But regardless, to power a nebulizer, oxygen, air would work. I need a compressed gas source. Now there could be a time, and those two gases have very similar densities. So the nebulizer would run pretty much the same regardless of which gas source I'm using. Now you see this new word called heliox. Heliox is a combination gas we will talk about in a couple of chapters from now, I believe. But heliox is a gas that contains oxygen and helium. Helium, an extremely light, very low density gas. If I run my nebulizer with heliox, I need to increase the flow 2 to 3 times that I normally would if it's oxygen or if it's air. Because the gas is very, 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 very light. And so I need to increase the flow if I'm using heliox, that compressed gas source, to power the nebulizer. Now we'll talk about what heliox is in a couple of weeks when we get to that particular chapter. So I don't want to get too much into heliox right now. But just understand that's an extremely light gas that in certain situations we will need to use for our patient, and we'll use it to power the nebulizer. Now, humidity and temperature, of course, can affect particle size. Aerosolized particles are hygroscopic, they retain moisture, so high humid environments, high temperature environments could affect nebulizer particle size and delivery. Characteristics of the medications themselves. Now, for a nebulizer, what do we put in that nebulizer cup? Some sort of liquid solution of that medication. Now, depending on what the medicine is, there could be certain medications that are a little more viscous than others, a little thicker than others. Inhaled antibiotics that we can nebulize tend to be a little bit thicker, and that could affect nebulization going through that device. Not necessarily to thin it out, no. Certain medications do require mixing with saline. We'll get into that when we get into drug pharmacology later. But not necessarily every single drug are we mixing, and it's definitely not to thin it.
Well, so like any of like the more viscous liquids, like sometimes they're just gonna have to stay like that. They're not gonna check.
Some of those more viscous solutions, we have to use very specific type of nebulizers that can handle that more viscous solution.
Might be a dumb question, but does Helios, can it raise their voice?
Yep, because it does contain helium. Anybody ever take the balloon and sound like what Mickey Mouse? You know, yeah, they will have a little bit higher of a voice, of course. All right, so 4 primary categories of nebulizers. 4. Some are more popular than others, and we'll go over each and every one. So the first one, a continuous nebulizer with simple reservoir. Continuous nebulizer with collection reservoir bag. I go over these and I'll show each one individually. If there's a breath enhanced nebulizer and a breath actuated nebulizer. Those are the 4 primary types. The first one, the continuous nebulizer. This is the most common. Probably already may have seen some of these in action already in the hospital. Nebulizer cup, mouthpiece, 6-inch corrugated tubing, compressed gas source to power the nebulizer. Looks like this. That medication is placed inside the nebulizer cup. Stream of gas takes that medication, slams it up against the baffle. That helps to break down the particle size into a much smaller particle size for the patient to inhale. As it's running, so just a little animation here. So as it's running, the medication's creating the aerosol or nebulization from the compressed gas source that's there. Now notice the patient hasn't inhaled yet. They just exhaled. Sorry, I must have missed the inhalation part. All right, they're exhaling. You can see what happened to all that medicine that's being nebulized or created an aerosol. But I tell you this, we're going to get half of a treatment from a patient just being next to them during this. Okay, now they're inspiring. Okay, we see that mist disappear. Now they're kind of between inspiration and exhalation. This is extremely slow pace. But my take on this, at least this schematic, again, the most common type of nebulizer you're going to see is notice how much is wasted. Every time this medication is being nebulized, it's creating these nebulized particles. Now when the patient inspires it, great, they're inhaling that medication. But when they're exhaling particles out, but nebulization is still doing what? Still occurring. When the patient's waiting between an exhalation and before they inhale again, there's going to be continuous nebulization. When you're giving this patient a treatment and they take it out of their mouth and they want to talk to you for a minute and ask you some questions, I'll be polite and say, okay, we can talk later, go ahead and put this back in your mouth and then make sure you're inhaling it. Because the longer they take it out and have a conversation with you, guess what they're not getting? They're not getting their inhaled medication.
Shut up.
Right. Being polite, making sure they inhale that medication.
So knowing that there is a great waste,
Mhm.
when you calculate the dosage, you're already considering the part that
It's yeah. When you're putting that medication in, you are not going to alter the dose at all.
I mean, like when prescriber
Mhm.
sets for X amount of
Yep.
dose is considering that already, that.
To a certain extent, yes. So when the dosing was created, it was based on this type of nebulization, this type of nebulizer. Understanding, sure, there's going to be a lot wasted into the room. That's what I said. We're getting at least half of the treatment from a patient just being in the room with them as this thing's continuously nebulizing. Wonder during our day our lungs feel more open and bronchodilated, and our pulse is going 100 miles an hour because there's some side effects. All right, so this is your typical standard small volume nebulizer. Now the animation doesn't show the 6-inch reservoir tubing, which it should, but I didn't create this, I stole it, so we'll have to just deal with that. All right, another type of nebulizer. This is a continuous nebulizer with a reservoir bag on the end of it. Now the term circulaire 2, that's the brand name. So you can see it phrased both ways. I think nebulizer with reservoir bag is a little wordy for me. If I'm saying, hey, go get me that nebulizer with the reservoir bag, that's a little bit too much, as opposed to saying, can you go get me the circulaire neb? That's just easier to say. So it does have a one-way valve, or they'll call it a flapper valve, that's located right here. You can't see it on my picture here, but you'll see it Friday. It is located right here. Now, so this part functions just like the previous nebulizer, connected into the compressed gas source, it's powering the nebulizer. It's creating an aerosol, and that aerosol is going into this bag. Okay, so the medication's going into this bag. When the patient inspires, they inspire, again from the mouthpiece, they inspire the contents of this bag, which what does the bag contain? The medication that was created. Instead of it going out into the room, it's staying in this bag for the patient to inhale. Now when the patient exhales, that one-way valve or that flapper here closes, allows them to exhale. Now we're looking directly at the exhalation port. So the breath would actually come out this way as the patient's exhaling. But while the patient's exhaling, guess what's happening? This is still nebulizing, still filling this bag with medication. So the patient, comparing the first nebulizer to this nebulizer, much less waste with this nebulizer. Kind of animation, it goes very quick here through this one, but you can see kind of that flapper valve. The wider blue aerosol is the medication being nebulized. The yellow is the patient exhaling. So it kind of goes through it really quick through this, but you can get the general gist of how the patient's getting their medication.
Would you worry about like what about getting like the larger droplets, like?
Not so much, because when, again, where that's going to occur would be if the patient's exhaling. I mean, I know this is creating an aerosol, but the patient's inhaling the contents of that bag. So there's not a worry of excessive condensation or anything like that.
Well, like with the inertial reaction.
That's the other particle size.
So we're not dealing with like large particle sizes like the.
Well, these type of nebulizers are producing particles anywhere from approximately 1 to 5 microns in size. So the quote-unquote ideal particle size for respiratory care and aerosol medication delivery. All right, third type, the breath-enhanced nebulizer. Breath-enhanced. Now, PARI, don't worry about the other part. PARI is a brand name nebulizer. Now, PARI nebulizers you typically see in the home. Cost comparison of the now 3 we've discussed or will be discussing, this one is the most expensive. Why you're probably not going to see it in a hospital setting, because we go through the nebulizers in a hospital setting pretty quick. And so, fairly expensive, but fairly durable. When the patient is using this in the home, as long as they're cleaning it appropriately, you're looking at probably a 6-month shelf life. As opposed to some of the other, the standard regular T nebulizer, you're talking a couple of days. No more than a week. So this one, even though it may be more expensive initially, because you're not having to replace it so frequently, probably going to be cost savings in the long run. And that's why you would see these more in the home type setting. All right, so this still connects to a compressed gas source, so that's still powering the nebulizer. When the patient inhales, not only do they inhale the aerosol medication that was created here, but they actually pull in and entrain some room air, which enhances the nebulization process, creates even more medicated aerosol for the patient to inhale. So when the patient exhales, notice there's no reservoir tubing, there's no bag on the end. The patient simply exhales here. There's a little flap that will open up when the patient exhales. But once they're finished exhaling, this will close back up. If the patient's currently not inspiring, there's still going to be some aerosol created here. But once the patient does begin to inspire, they will pull in from the room additional room air, which enhances the nebulization process for them to breathe in that medication. Kind of let that run through with animation here. Animation goes super slow through this. So, not the same as the circular nebulizer, but again, the point here, minimal waste. Minimal waste compared to the T-neb, where so much of that medication is going to be wasted. You can see when they exhale, that little flap on the top opens up to allow exhalation. But nebulization is still occurring even when the patient's exhaling. So there could be a little bit of a loss here. Now the patient's waiting, they're inspiring. You can notice how much aerosol enhancement is created when the patient is breathing in. Again, something you more than likely see in a home care type situation, not so much in a hospital. And again, it's all related to the expense of the nebulizer.
On that one, do they have to breathe in deep or just regular?
Good question. So for all nebs, and we'll kind of talk about this in just a minute, regular breathing. Regular, normal, tidal volume breathing. They don't have to take in a super deep breath like I would encourage them to do if they were taking an MDI or DPI or Respimat. This one they could just kind of breathe regular, breathe normal. All right, the last one, breath actuated nebulizer. Breath actuated nebulizer. Now, cost-wise, this is not as expensive as the breath enhanced. It's not as expensive as that PARI nebulizer. You may see these in the hospital because they are a more efficient nebulizer. Again, we have oxygen tubing to power the gas source to power the nebulizer. We have openings here, so similar to the breath enhanced, and we'll see it kind of in action where the patient will pull some air in through the top. It also has this little green button. They call it an actuator that we will notice moves down and up, depending if the patient's breathing in or not. Again, remember the name, breath actuated. If I have this program then set to work with breath actuation, it's only going to nebulize when the patient is inspiring, not when they're exhaling. I know it's difficult to see here at the top where this green button is. They're kind of little flaps or wings. I'll just put pictures here. Can't really see this very well either, but the little flaps or wings here that can turn and rotate. I don't know if you can see this. Kind of looks like a triangular shape, but a bunch of little dots. That is on breath actuated mode. So right now it's turned where those are lined up here. If I turn this down to this kind of solid triangle, that's continuous nebulization mode, where no longer would it be breath actuated. It will just continuously nebulize, like a regular neb, standard traditional neb does. That green button on top can be a clue for us, a clue for the patient when that nebulization is occurring. When it's on the on-demand version, like it is right now, the breath-actuated version, that green button is going to freely move down when the patient inspires. When the patient finishes inspiring, it's going to pop back up. And nebulization would not be occurring. If I force it in that down position, it's just going to continue to nebulize. And so you will notice and see that little green actuator button moving up and down, up and down. When it moves down, nebulization is occurring. When it pops back up, nebulization is halted or ceasing at that moment. Again, something you will see on Friday. Again, these things, we have them, I wouldn't necessarily say every single one is clean. We have some that are still in its package, brand new, so those things we can open up and somebody can try it or experiment with it if you want. But we can actually force the button down, you'll see it creating a nebulization. We'll let it come back up, we'll see nebulization stop. So, similar, I say, to the breath enhanced nebulizer. Again, still going to have the compressed gas source powering the neb. Nothing's going to happen as far as aerosols being created, even though you can hear the gas source going through there. Once the patient begins to inspire, they're going to begin pulling room air from the top, similar to the breath enhanced nebulizer. That's going to help to increase and maximize nebulization for the patient to pull in that medication. When they're done and finished and exhale, there is a flap on the bottom. I don't even call it a flap. There's a venting area on the bottom of the breath actuated nebulizer to allow the patient to exhale. The breath enhanced one is kind of on, the flap is on the top.
You said this one, you take in room air too?
Yes, yes. But again, if I'm connected down here to an oxygen flow meter, then oxygen's going through there, but I'm still pulling in room air when the patient inspires. And that's when that green button will go down, moving that downward position. Sometimes you'll hear these called BAN nebs, B-A-N, which is fine, I have nothing against that. Then it gets confusing. Does that mean the breath enhanced are called BENs? We don't call them BENs. B-E-N for breath enhanced nebulizers, we don't call them BEN, but for some reason we call these BAN nebs. So just be careful on that. If I'm emphasizing breath enhanced nebulizer, I will say it all. I won't call it a BEN nebulizer. But this one you could hear referred to as a BAN neb, breath actuated nebulizer. All right, so regarding infection control with nebulizers, CDC, Centers for Disease Control, recommends nebulizers should be cleaned and disinfected after every use, rinse with sterile water, and air dried between uses. That does not happen in the hospital setting. I'll take this right now. That does not happen in a hospital setting. But that is the recommendation. What happens in the hospital setting? When they're finished, we tend to open them up, kind of shake them out, dry them out, we put them back together, we fold them up, and we stick it back inside of a treatment bag. And we seal the treatment bag and we hang it on the flow meter, waiting for the next time. But those things aren't going to be left for the entire patient's hospital stay. Depending on the hospital, those things could be replaced every 24 hours or every other day, 48 hours, just depending on hospital policy. But I guess we're just trying to keep everything in there clean. But we don't have room, there's no space to be able to sit there and clean them the proper way and allow them to air dry. With everybody else who's coming into the hospital room, they could bump and knock the things on the floor. So you won't see that done in a hospital setting, but you would definitely encourage your patient in the home to make sure you clean them correctly. With the medication cup just below the mouthpiece or the mask of a patient's own secretions, their own drool could be pooling down there. And I will always say this, and again, when you're in the hospital, I'll defer to whatever the hospital says you should do in the situation. But I would say, if it's not that big of a deal, and you notice, man, this nebulizer is kind of nasty or junky, or is that eggs from breakfast hanging on the mouthpiece? I threw it in the trash. Can I get another nebulizer? You guys will probably be exposed to where all the equipment's kept. You probably did a scavenger hunt in some of these places, right? So you see one that's nasty, they're like, man, if this was me, if this is my loved one, I don't want it to be replaced. Whoops, I guess I threw it away. I need a new one. I can't do that with medications, right? No with medications. But the nebulizer, we can easily replace. Because again, I don't want that to be contaminated. All right, here's kind of the technique from the book. So let's see, for using a small volume neb, assess patient for needs, select mask or mouthpiece for delivery. I will say this, depending on where you're at, make sure we're following hospital protocol and policy when it comes to nebulizer delivery. I will say that a mouthpiece is probably going to be the most efficient way to deliver a medicated aerosol, medicated small volume aerosol. With the mask, the nose is such an effective filter that I wonder how much of that medication is being filtered out by the nose. Okay, now I will say, anybody plan on working night shift? You're going to go in that patient's room every 4 hours. Excuse me, ma'am, excuse me, sir, it's time for your treatment. Here, John says mouthpiece is recommended, and the patient keeps falling asleep on you. Now I get it, there's going to be some times like, okay, patient, just relax, just breathe normal. I'm going to put this mask on, keep your eyes closed. You go back to sleep, you go back to sleep. You know, we'll deal with it. But in a perfect world, I think a mouthpiece is going to be the most efficient way to deliver that medication. Again, conserving system, if we even have such a thing, but breath actuated would be one of those ways. Place the drug in the nebulizer. We'll do all that stuff according to manufacturer recommendations. Set gas flow 6 to 10 liters. Again, follow manufacturer's recommendations. Again, what you're going to see more than likely is about 6 to 8 liters a minute. Coach the patient to breathe slowly through the mouth at normal tidal volume. So unlike the MDI and DPI that we say, okay, take a big deep breath in and hold it, I don't have to do that with this. Just think about it. When are they getting the medication? Every time they're breathing in. It's not like a one-time thing, like they would only get that medication if they just breathe perfect for that MDI or that DPI. This, because it's continuously running, they can just breathe normal. Breathe normal. If the patient says, is it okay once in a while if I take a deep breath and hold it? It's not hurting anything, but it's not necessary. It's not necessary. Continue the treatment until the nebulizer begins to sputter. Okay, I'll talk about sputtering in just a second. Again, what we should do, rinse the nebulizer with sterile water, air dry between treatments, or throw it out, monitor patient, assess outcomes. Okay, so less patient dependent on technique with the nebulizer. That's why you're going to see most patients in a hospital, more than likely receiving a nebulizer. That's why patients in an ER who are short of breath, as opposed to trying to get them to time a breath just perfectly with an MDI, well, just go ahead, just relax, try to breathe as normal as you can, sir. We'll get this nebulizer running on you. Even though it could be the same medication in the nebulizer that does come in that MDI. All right, nebulizer sputter. When the nebulizer begins to sputter, so initially you put that liquid medication in there. That liquid medication could be anywhere from 3 to 6 plus mLs of liquid solution inside that nebulizer. As long as you put it in there correctly, it's going to take several minutes for it to run. People say, well, how long is several minutes? Well, it depends on the quantity of how much medication in there. Sometimes we put 2 medications in there at the same time, so that's going to increase the quantity. But generally speaking, probably anywhere from 5, 10 minutes, 15 tops, if we have lots of solution inside that nebulizer. But I'd say 10 minutes, give or take, plus or minus a few minutes here or there. But at some point, when you turn it on, blow an aerosol, or if it's the breath actuated one, you press that green button down, you see the nebulization, okay, it's working right, here, patient, you take it. But at some point, you're going to see that aerosol not come out so smooth anymore. And we call that when the nebulizer begins to sputter. Now, first off, make sure they're holding the nebulizer correctly. I'll try to remember to tell you guys this on Friday, but if the nebulizer cup is my remote here, and there's a certain level of solution, and it requires that certain level to nebulize. If I was to take that nebulizer cup and turn it to the side, well, guess what's going to happen? You're going to begin hearing sputtering. Okay, that's not the sputtering I'm talking about. That's simply sputtering by turning it the wrong way. As long as it's upright, perpendicular to the floor, as that medication continues to run and that level gets lower and lower and lower, okay, at some point, it's going to get so low where the nebulizer is not able to create the aerosol anymore. It's such a low amount of liquid medication. That's the point where I'm saying, okay, sputtering begins. Now at that point, if you look at the graph here, sputtering begins. This represents volume remaining and output, talking minutes here, mLs per minute. By the time it begins to sputter, it's just a matter of a few seconds, a few moments later, that aerosol efficiency, what's coming out of the nebulizer, is significantly reduced. By all intents and purposes, I would say by the time a medication begins to sputter, the treatment is essentially over. Now, when you go and take that nebulizer from your patient, they may say, okay, next, here you go, you know what you're doing, okay, it's sputtering. There could still be some liquid solution inside that nebulizer cup, and that's okay. I will open the nebulizer cup, dispose of that in the sink or the trash, close it back up, don't want to have any extra solution in there. But you may have, and what's that special patient population that I always say every single class, I'll find a way to incorporate them? Those people, right? Those people who take these medication, these nebulizer treatments religiously every single day. The second you try to take that nebulizer from that patient's hand, they're going to snatch it back from you, going, there's still medication in here. And you'll see them. There may be a very low level of liquid, but there's still going to be some of that aerosol liquid on the side of the nebulizer cup. They're going, no, there's still medication in here. And they're going to tap it down to get back to that level. That's okay. I'll let them. I'll appease them. Okay, you're right. There's still a little bit left in there. Go ahead and finish that up. It's literally, it's another minute or two tops before it finally, and they'll, oh, here you go. Now you can take it from me. Fine, ma'am, sir. That's okay.
Is this like a regular ratio for like all nebulizer treatments, or like if the more viscous the liquid is like the time going to increase?
It could. so longer time before it ever reaches the sputtering stage. All right, so just want you to make sure you understand when it begins to sputter, and you can let it go for another 15, 20 seconds if you want, but essentially by that point, it's over. But if the patient doesn't want you to take it from them, I warned you, and that's fine, let them go ahead, let them finish it. All right, sorry, I thought you were done, I'll give you another minute. Won't take much longer, But you can see how efficient the medication delivery is after it begins to sputter. All right, let's see, what did I forget to say? All right, so small volume nebulizers are much less technique dependent compared to an MDI or even a DPI for that matter. They do not have to take a rapid inspiratory flow. I think the only aerosol delivery we mentioned up to this point that requires a rapid inspiratory flow is the DPI. MDI, slow. Nebulizer, slow inspiratory flow. Deep breathing, breath holding do little to enhance medication delivery over just doing regular, normal, tidal volume breathing. The mask or mouthpiece, which I did mention before, again, based on patient's ability. I mean, some patients, think about your comatose patient. Are they going to hold that nebulizer in their mouth? No. That right there, okay, we're going to use the mask on this patient. Patient may have preference that they want to receive it with a mouthpiece or mask. I will appease them. I will, whatever they prefer, I will, lead them to. And comfort. However, many respiratory therapists do prefer not to use a mask because the nose is such an effective filter. But like I said, at night, the patient is dozing off on you, yeah, and maybe the only way you can get them to take that medication is by giving them a mask. I mean, you hand the patient a mouthpiece, you turn your back away, maybe you're charting something, the next thing you know, you hear the nebulizer sputtering, and it can't be done that fast, and they've fallen asleep and the nebulizer over on the side. All right, comparing those 4 different types of nebulizer delivery systems. Now, what's in blue represents what the nebulizer is producing. These lines represent what the patient is inspiring. So, standard regular T-neb. Patient's inspiring a whole lot more than what is actually being delivered to them. When you think about it, that reservoir tubing, you see that mist disappearing on the end, patient's still breathing in regular room air. So all that additional air is up here. But how much of that is really medication? It's a very small amount. And notice it continues even when the patient is exhaling. All that waste that's coming out the back end. The circulaire, the one with the reservoir bag, if the patient's inspiring the entire contents of that bag, look how much more medication they're actually able to get. Now you may wonder, well, there still is some loss. There still can be some loss, but they're getting much more efficient inspiratory delivery of medication.
The loss would be when the exhale to resolve the valve that is.
Right, the valve that's here that allows them to exhale. Again, it's not a perfect system. It's not a perfect system because think about it, this is still nebulizing all the time. And so this represents a little bit of waste. But just comparing A to B, they're getting much more of that medication. And believe it or not, the amount of medication that you put in this is the exact same amount of medication that you put in this. So talk about dosing. Yeah, it's the same dose, but which patient probably receives more of that dose comparing the two? This one. The breath enhanced versus the breath actuated. Again, this looks very similar to the circulaire, the one with the bag, because again, there still can be some loss even when the patient is exhaling, but as long as this is turned to breath actuated mode, there's going to be absolutely no waste because this does not nebulize during exhalation. Now you do know I can set this up just by turning that dial at the top to go continuous, and then the diagram would look like this. But as long as I set it the way it's intended to be set, this is what we're going to see. And again, it makes sense. They're only getting the medication when they're inhaling.
So in what situation would you turn a dial?
Oh, good question. So, this is a great nebulizer, don't get me wrong. If I had to personally pick one, this is the one I would pick for myself, or my loved ones, or my family. But it does have limitations. So, let me ask the question, when does the medication nebulize?
Inhalation.
When the patient's inhaling. Let's say it's 88-year-old grandma who can inhale very deeply. She's taking, because of her illness, disease, weakness, whatever, she can only inhale. So for example, you and I, even if I'm just kind of trying to breathe somewhat normal, how long is it going to take me to inspire? 3 seconds, I'm not even really trying. All right, 3 seconds. But weak patient, I'm not even inhaling for a second. This is only going to nebulize when the patient is inhaling. If they're so weak, they can inhale very deeply or very much or for very long, they're not going to get much of this medication. In a situation like that, I probably would then turn it to continuous. So it's a constantly there, even though the patient still, that doesn't help the patient take deeper breaths by any means, but that way the medication's right there the second they inspire. They're not having to physically pull it in themselves. It's right there. So that may be a situation where you do turn it to continuous.
Now, if they're if their inspiratory muscles are not strong at all, and it's going off continuously, even if they're not inhaling, will still go down to their lungs if they're not inhaling?
No, it's only going to go as far down as they can inhale.
Okay.
So again, and that's just one example, one reason that maybe that particular patient's medication delivery is not so efficient. We'll talk about things in a couple of chapters from now where we can assist with deeper breathing, and we can then put that same medication in one of those devices and maybe help to improve deposition deeper and so on. All right, so let's move over to the large volume jet nebulizers. So these are not the bland aerosol delivery systems we talked about the previous chapter. This is for delivery of aerosolized medication. So inside that large volume nebulizer, we actually put medication. There's actually medication going to be in there. So visually, they look similar to the bland aerosol delivery systems we've talked about in the past, but they are going to be different. They're going to be different. They're intended, so they're going to come empty. We have to physically put the medication inside of them. And we have to put quite a bit of medication inside of them. The reason we use something like this is when we have a patient who's in bronchospasm, and bronchospasm means the distal airways are constricting. What sort of patient does that happen to? Asthma patient. I thought somebody was going to say COPD. Not that it couldn't with a COPD patient, but I'm specifically talking about asthma patients. So their airways are constricted. Now what do we give them? We give them a breathing treatment with a bronchodilating medication, and the patient's probably already taken their inhaler at home. It's not working. They've taken another dose of their inhaler at home. Still not working. They're calling their doctor. They're calling 911 maybe. It's that bad, or they're showing up at the ER. What do we give them? Small volume nebulizer treatment with that same medication, trying to open them up. Their airways are not opening. And so we end up giving them small volume nebulizer back to back to back. 3 treatments back to back to back of this bronchodilating medication. And guess what we're noticing? Still no response. They're still wheezing like crazy. Their airways are getting tighter and tighter and narrower and narrower. We can do something like this large volume nebulizer, where there's continuous bronchodilating medication inside that nebulizer cup. And when I mean continuous, I don't mean for 10, 15 minutes. I mean for hours. We could put them on this continuous for 6, 8, 12 hours to try to break their bronchospasm. And so that's what I mean here by this continuous bronchodilator therapy. So it's still the same type of medication I put in a standard small volume neb, but because I'm expecting this to last a lot longer, have to run a lot longer, there's much more liquid solution of that same medication I put in the small volume nebulizer, but much more of that medication inside this large volume nebulizer system. There's different brands. I don't care that you remember the brand names here. High output, something, I can never remember. High efficiency aerosol respiratory therapy, they have different meanings, but those are just the brand names. But I'm going to call these just simply continuous bronchodilator therapy.
This is only the hospital, not like home.
Correct. Correct, yeah, if the patient has to have this in the home, no, they need to be in a hospital setting. Because there's all kinds of side effects that we have to watch out for with giving them so much of this medication. Another large volume nebulizer that is out there that you will see very, very, very infrequently, if at all. I'm still surprised it shows up in the textbooks. The SPAG, Small Particle Aerosol Generator. It is a specific device intended to only give one medication, and that's ribavirin, an antiviral medication for RSV, respiratory syncytial virus. It's the only nebulizer that can deliver aerosolized ribavirin. Aerosol is the brand name. Still very, very, very rare that you would ever see this in action. But if you did happen to see it, somebody needs to get on a call. Say, guess what I'm seeing right now? You are? Okay. Let me talk to the RT. I need some questions answered. No, I'm just teasing about that. But very rare that you would see this. If you're ever in the respiratory equipment room and you see, hey, there's a row of small particle aerosol generators, hey, take a look at that. That's respiratory history right there. That's probably covered, right? Very rare. It's probably covered, and if you just kind of wipe the top of it, you wonder why all this dust here. You just imagine the last time it was actually used. Anybody want to ask the question why? This medication, thank you. This medication is super, super, super expensive, and when you read the reports, they're not even sure that it actually even works. The studies have shown there's really no increase or decrease in mortality or morbidity when a patient takes this medication. You've probably all heard of RSV. We're getting ready to start the respiratory syncytial virus season, RSV season. During COVID, when everything was shut down, the rates of RSV went way down because we weren't around each other to spread it. Mainly you see this with kids, young kids. Most kids, by the time they reach 2 years of age, have been exposed to this. It's a virus. I don't want to minimize it and say it's like a common cold virus, but it's going to run its course, and generally symptoms are mild and manageable by over-the-counter means. There's no reason to justify spending the $30,000 it takes for a single treatment when this may or may not work, right? Well, a used car by today's numbers, right? I didn't say 50K, 30K. But it's still in the books, it's still on the board exam matrix, so you still got to remember it, but it's very unique. It's only intended to deliver that medication. Ribavirin for RSV. Can't drop any more helpful hints. Handled atomizers and nasal sprays. These are all kinds of different classifications of medications, sympathomimetics, anticholinergics, etc. Think about a nasal spray that the target is the sinuses, is the nose. Even though it is an aerosol, the particle size are going to be too large to reach our lower airway. So yes, it's still classified as an aerosol, but the intended delivery site is probably the nose or the sinuses. Again, think of hay fever, rhinitis, seasonal allergies, etc. Some folks may have to take these. Maybe it's an inhaled anti-inflammatory agent, steroid type agent to reduce inflammation in the sinuses. Maybe it's what's that? Yeah, that's where I was going. What's the name? Don't answer. What's the name of that inhaled spray that it's on a lot of rescue units? It's sometimes right next to the AEDs for patients that have overdosed on fentanyl or some sort of narcotics. Naloxone, otherwise known as Narcan. That nasal spray. My son, when he graduated now, but when he started at FSU and we're moving him into the dorms, right there on the ground floor, they got Narcan right here. College students, and that's potential, I guess. And so I showed him, hey, if you ever have to use this with one of your friends or whatever, this is how you do it. But again, it's a nasal spray. It's a nasal spray.
There's also some procedures like that.
Sure, yes. Absolutely. All right, ultrasonic nebs that did appear in the bland aerosol category. Again, electrically powered, uses a piezoelectric crystal to create vaguely familiar, vibrational energy that goes through some sort of water solution using sound waves to then hit the medication cup where the medication is currently housed at. Again, to create a very fine, small aerosol particle spray. A lot of home nebulizers use this sort of technology. Something that can be used in the home, could be used outside of the home, battery-powered type units. A lot of those use ultrasonic technology to power those nebulizers. Vibrating mesh nebulizers. Now these are a newer classification of nebulizers. Vibrating mesh. They use a dome-shaped aperture plate or a mesh, hence the name, vibrating mesh nebulizer, with thousands of small holes inside of it. Uses electricity, so it's not a pneumatic device. It uses electricity to cause vibrational energy pulling the liquid medication to these very small holes. Again, it's too small for us to see with the naked eye. We can see where the aerosol is being generated, but way too small to see with the naked eye. And you can see a very fine aerosol delivery with a vibrating mesh nebulizer. Residual drug volumes are extremely small, so before it ever has the chance to quote-unquote sputter, 0.1 to 0.4 mLs of liquid solution, it would have to lower to. So the patient ends up getting a much greater dose of the medication that's being provided compared to traditional nebulizers. Just to point out what's on the screen, this is actually the nebulizer cup. What's hard for us to see here, that's where the mesh or aperture plate is. Same thing here, this is where the mesh or aperture plate is. This little piece, we simply open that, we can inject the drops of liquid medication. This is the unit that actually powers the nebulizer. I don't know if you can see this very well, but there's going to be a connection between this unit and this piece. This piece will be plugged into electricity. Pretty straightforward and simple. Blue button here on the top, you press that, it's going to cause nebulization to occur. You press and hold it keep it held down for 3 seconds, it will cause continuous nebulization to occur. If you just press it one time, it'll nebulize for 30 minutes and then automatically shut itself off, or until you press that blue button again. Here's kind of a better zoomed in picture of the cup itself. The mesh plate is here. This is what it actually looks like. Again, the super teeny tiny holes as this unit vibrates, pulling the liquid solution through it, creating a very fine aerosol. You'll see these on Friday run. We'll compare the 4 standard nebs that we talked about. We'll kind of run those, examples of those, get them running, see what it looks like and how to set it up for a patient. And then we'll have this one set up. And you can see, just based on what you can visually see, which one looks like it's probably a more efficient nebulizer, more efficient aerosol. Now these are newer. These are going to be more expensive by comparison. Where you're typically seeing these used right now is more in the ICU with our mechanically ventilated patients. So that's something you'll see in due time when we start working with mechanical ventilation patients and giving them aerosolized medication. You may be seeing this type used and not some of the others. All right, so when you select these things, well, even the MDIs, DPIs, RESPAC, which one is best? Which one is best? They all work with comparable clinical results, as long as they're used for the right patient and used correctly, of course. But as far as saying one is superior to the other, that's, again, you're going to have ones that you prefer over others, just based on your personal experience and where you've seen it work maybe more with patients. But again, according to the literature, according to the studies, they all work about the same. But it is important for us to know the strengths and limitations or strengths and weaknesses of these devices when it comes to which one we should select, if we have the opportunity to select it. Now I will say before we go over the next slide, number one is, I know the patient needs this particular medication, what form does this particular medication come? Can it come in all different forms, MDI, DPI, Respimat, nebulizer, whatever? You know, of course, that's the option, then yeah, pick whatever delivery device you think is best. But if it only comes in one or two versions, okay, well then I can't get so nitpicky. The patient needs that medication, but it only comes this way, well that's the way I'm gonna have to give it. So, this is from the textbook. Showing some of these different types of aerosol delivery systems. Let's talk about cost. Alright, notice, well, one does say low. Gee, what do you think we use most often in the hospital setting? I wonder why. But you can see what some of the costs are versus some of these others that are much more expensive. Portability, because it's small. Yeah, MDI, that should be very portable, so high. Intermediate, when you say, well, now you got to carry this stupid spacer holding chamber with it. DPI, again, pretty portable. Low and small volume NEP, again, there's parts and pieces that can get missed or dropped or forgotten about. The others, intermediate. The coordination issues, we know definitely it's high with the MDI without the spacer holding chamber. The others should be pretty simple to use. What about preparing the medication? Well, if it's an MD or DPI, there's no prep really involved. I will say maybe with the DPI, if you have to load one of those DPIs, I guess we can call that a little bit of a prep, versus the others that you do have to mix some medications together. Oropharyngeal deposition, you can see where it is high on some of our MDI DPIs, and again, that's even still with best coaching technique. Medication availability, again, some with the MDI and DPIs, a lot more in the nebulized versions of the medications. Contamination risk, going to be higher on that nebulization side. Noise, and MDI, DPI shouldn't be very noisy, right? But nebulizers tend to be a little bit noisier. Treatment time. That's one thing. Think about your poor patient. I got to do this 4, 5, 6 times a day. And it's going to take me how long to do this? 10 minutes every single time out of my day? That's almost an hour if I'm taking it 6 times a day. As opposed to much shorter if it's an MDI or DPI. So again, things to consider. And I would say here's your advantages and disadvantages of one device compared to another. And what is the hospital always going to look at? Yeah, we could go over this with them all day long, but they're going to look at this number one, of course. And so when you wonder, well, why don't we just switch and go all our patients with an MDI? Well, it's going to be more expensive as opposed to the small volume NIM that we're using right now. All right, so selecting, so I got to look at my notes here for a second. I know there's a good chunk of this chapter I'm omitting. So kind of starting on page 861, it's kind of where this starts, and I'll just mention this for a second. But there's probably another 10, 12 pages. I'm not getting into any details regarding that information. It talks about how to deliver these medications with mechanical ventilation, how to deliver these medications if someone's on CPAP or BiPAP, how to deliver if they're on high flow cannula. We're not ready for all that information yet. We'll get to that in due time. So if you wanted to jot a page number down, omitting pages 861 through 873. You're not going to be responsible for any information from those pages, 861 to 873. This is the last piece on page 861 I will kind of mention, that clinical efficacy varies according to both patient technique and the device itself, but best approach to aerosol drug therapy is to use some sort of assessment-based policy or protocol. Instead of just saying all of my patients need to have a vibrating mesh, or all of my patients need to have a DPI. No, we got to tailor it to each and every patient based on the strengths and weaknesses. Now, things that could affect aerosol drug deposition in the lung without getting too much into this: mechanical ventilation, artificial airways. Think about whether it's an MDI or even small volume NEP. That medication is going to have to go through what to get to the patient? A very narrow endotracheal tube. Ventilator circuitry, perhaps. But again, very narrowed endotracheal tube. How much of that aerosol do you think impacts the ventilator circuit, impacts the ET tube or trach tube before it ever gets into the patient's lungs? So you may notice, and we'll get to this a little bit more in time, dosing for those sort of patients may be higher than if it was for my non-intubated, non-mechanically ventilated patient. And you guys can look at some of the others there. But again, specifically pointing out mechanical ventilation, artificial airways can definitely affect medication delivery through an aerosol. All right, last part here. This is on page 873 about pneumatic nebulizers producing lots of secondhand aerosol. And of course, you can hand pick of those 4 nebulizers, different types of small volume nebulizers we talked about, and say which one has the greatest potential to have secondhand contamination, right? That's that first one, the standard one. And which is the one you're going to see most often in a hospital setting? That one, the standard regular TNAP. So passing that aerosol directly into the patient room, patient environment where we're standing around waiting for the patient to finish that medication. Now, sometimes some of the medication we're nebulizing can be toxic, even to us. And so in those situations, maybe the patient needs to be in a very specific location when they receive that aerosol medication from us. A negative pressure room, which kind of pulls out any exhaled air into the room, the same type of room we would put our patients in airborne isolation, a tuberculosis patient. Plus, I would probably want to have the proper PPE, the N95 mask to protect myself. If we didn't have those, some places may have specific treatment booths. Anybody old enough to remember what an old phone booth looked like? I can't help but picture a phone booth here where a patient goes in, there's chairs, there's a place they can sit down and take their nebulized medication, where we are on the outside of that room. Again, it pulls any exhale, just like a negative pressure room, pulls any exhaled or aerosol that's generated in that room, pulls it out and vents it to the outside. Again, we should have our own proper protection. Again, mask, N95 mask if we're trying to have the highest filtered mask. There's another medication. So there's really only 2 meds from this whole chapter that I did bring up. One was the one used with the small particle aerosol generator. The second one is the drug pentamidine. Pentamidine. Pentamidine is a medication used for patients with a very particular type of pneumonia. We'll get to that next semester with different types. But with a very particular type of pneumonia. That medication can be extremely toxic to us. And so if we're giving it, yes, we can put them in a negative pressure room. Yes, we can make sure we're wearing the proper N95 mask. Or we can put them in a treatment booth instead of just the negative pressure room. But in this example, for this drug pentamidine, we need to give it with a special type of nebulizer. So a nebulizer that goes by the name the Respigard, or Respigard 2 to be official. But if you look at the nebulizer, it looks like your standard traditional nebulizer, but with some slight modifications made to it. So you can actually make one of these yourself in your hospital with parts and pieces that are available to us, or your hospital could decide to purchase the Respigard 2 nebulizer that has all the parts and pieces already together. But we can actually make one of these things. So what does it contain? Standard nebulizer, oxygen tubing, gas source tubing to power the nebulizer. Has the corrugated tubing, the reservoir tubing, just like a standard TNEB, but it does have a one-way valve. That prevents that medication from going out this end. So you would never see any mist coming out this end. As it nebulizes, when the patient inhales, they inhale that medication directly. When they exhale, there's a one-way valve here that allows them to exhale this direction. They don't inhale through this part, they only exhale through. And what's here at the very end? A filter, a bacteria filter to capture any exhaled particles, so we don't come in contact with it. Again, I would still prefer that they're in a negative pressure room or a treatment booth. I'm still wearing my N95 mask, but we're also using this type of nebulizer for that specific medication. Again, if the patient wants to inhale, this one-way valve will open and allow them to breathe in through here and pull in the medication that's being created. But when they exhale, this valve closes, prevents them from exhaling back here, and only allows them to exhale this end. So it's a standard T-neb that's been slightly modified with what I would simply say one-way valves and a filter. Yeah. It's not as common as some of the others, but if that specific medication had to be administered, this is how we would have to give it. So I didn't want to get too much into different drug names, because this is not a pharmacology class. We have that next semester, but because this one is given with this particular type of nebulizer, and the small particle aerosol generator uses a very specific medication to deliver, those are the two drugs you have to know their names, because they are associated with those particular type of aerosol generating devices. The Respirguard or the small particle aerosol generator. But no, to answer your question, it's not common. It is not a common medication to administer. But I will say it's more common than using the small particle aerosol generator. But it's not as common. Any questions?
Really simple math, you said something about like dose filtering on a medication. Do you like increase the dosing of those patients?
No. When the physician writes an order for a dose of medication to be delivered, so when I mean dose, there's such and such milligrams of medication to be delivered, we are not altering that medication dosing. That dosing is coming from the physician. Now I will say, when it comes to dosing, and again, we're not changing the dosing. We're getting that dose of medication in that liquid solution. We're putting that dose inside that nebulizer cup. Now, based on the different type of nebulizers we have available to us, we know some are going to be more efficient than others. Always think about this. I wonder which patient received the most of that medication that I was delivering. Those with those more efficient nebulizers. And there is a lot of debate and controversy right now, because in some places, not all, but in some places, we're using much more efficient nebulizers now. How much more of the medication is the patient receiving than if we were just using the standard T-neb? Because the standard T-neb is what they were all tested on originally, and that's where they came out with this particular dose. Knowing the standard T-neb, how much of that is going to be wasted, a good amount, so we got to make sure the dose is here. But with more efficient nebulizers, where there's much less waste of that medication, how much more is the patient actually receiving from us? Again, that's something that there's discussions happening, but nothing's changed yet when it comes to dosing. Because you can imagine, maybe one hospital uses one type of nebulizer, a very low efficient nebulizer, and another hospital uses a much more efficient nebulizer. But the dosing is still standard, the dosing is still the same. But you can only guesstimate that, that more efficient nebulizer, that their patients are probably seeing a little bit more of that medication than the ones we're using with the less efficient nebulizer. Any other questions? No? All right. Here's my questions for you. I'm only give one question. I have several questions today, guys, so bear with me on this. This is a little bit more unusual as far as the number of questions I'm giving you guys. Hopefully there's room on your phone. All right, first question. What is a disadvantage of using a pressurized meter dose inhaler versus a dry powder inhaler? Is it, again, disadvantage? Is it requires a high intraoral flow, most units are single dose, coordination difficulties, or contamination? Disadvantage of using an MDI versus a DPI? The coordination. Coordination. That is the biggest disadvantage of using a meter dose inhaler. Now, what changes that issue? Even if it's an MDI? The holding chamber or the spacer. And that makes a big difference, using a holding chamber or a spacer. In the hospital setting, you go to take care of a patient, or you go to coach or educate a patient on how to do an MDI, I'm grabbing a spacer, I'm bringing a spacer. Whether they want to take that home with them and use it, that's entirely their prerogative. But if I'm going to teach them the best way, I'm bringing a spacer or holding chamber with me. All right, next question. Which of the following devices is most suitable for the delivery of Aerosol or ribavirin? Is that a small volume nebulizer, small particle aerosol generator, ultrasonic neb, dry powder inhaler, or Respimat inhaler? This is the SPAG, right? Small particle aerosol generator. Again, it's one of those two medications that I said you have to know specifically that medication name, because it requires a very specific nebulizer. So this one's the small particle aerosol generator, or SPAG for short. You okay with that one? Got that picture all right? All right, next question. What type of nebulizer I could write better than this. What type of nebulizer pushes liquid through a mesh plate or aperture to create an aerosol? Is that an ultrasonic nebulizer, Respimat, DPI, VMN, MDI? ABC, XYZ. All these acronyms, right? You can even see it here. And what is it again? You guys are right. I'm just dragging this on. Vibrating mesh nebulizer, or D. Now, the vibrating mesh nebulizer I shared with you guys was one that you would see in a hospital. They do make them electrically powered that can be used in the home or outside of the home. Again, battery powered. Vibrating mesh nebulizer technology. It is the future of nebulizers. All right, everybody okay with this one? VMN, vibrating mesh nebulizer. All right, next question. Name the following device. Small volume neb, traditional T, breath actuated neb, van, breath enhanced nebulizer, circular nebulizer, Respirguard nebulizer, VMN. D? You sure? D? Be confident. Live with your decision. It is D. It is the circulator. It's the one with the bag on the end of it, right? One with the bag on the end of it. The flapper, you can actually see the flapper piece here. Nebulizes, all that medication stays here. When the patient inspires, this flap opens, allows them to pull the medication from that's nebulized in that bag. When they exhale, this flap closes and they exhale out this end. You'll see these on Friday. We have plenty of these to look at on Friday. So this was D, circular nebulizer. Next question, which one is this? This is breath actuated. This is the breath actuated, or B. You will see this one used in a few of our hospitals in town. Circular, you don't see too much. The one with the bag on the end, you don't see that one too much. This one you do see. Traditional one, absolutely you'll see. This one probably is at least of the four primary ones, this is probably the second most common one you would see. All right, next question. Which one is that? This is actually the nebulizer cup, and there's something right here that does one of these things, creating an aerosol. This is the vibrating mesh nebulizer. These have been out for a good number of years, but I was doing a review, this was just a few years ago, doing a review with my second year students, and I asked a question I thought I was going to get the answer I was looking for, and I said, how many folks in the class have seen a vibrating mesh nebulizer? Not a single hand went up. And I said, I don't believe that. You guys had to have seen these. So I don't know what you're talking about, John. I said, well, what nebulizers have you seen? So they're going through the list of what they've seen. And somebody said, Aerogen. And I said, oh, Aerogen, that's a vibrating mesh. Who's all used the Aerogen? Every hand in the class went up. Again, we get used to calling things by the brand name and not the very generic name. Aerogen, when you guys see the Aerogen, that is probably one of the most common, at least in the hospital setting, one of the most common types of vibrating mesh nebulizers. So it's a brand name, Aerogen, just like, what do we call these things? Kleenex. Kleenex is a brand name, right? They're really tissues, right? Facial tissues. But that's too complicated. We call it Kleenex, just like they call this Aerogen and not necessarily the vibrating mesh nebulizer. All right, so this one was F, vibrating mesh neb. What are we looking at here? That's what all I heard. Blah, 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 blah. So this is A, regular, traditional T, standard, whatever other generic way you want it, regular, and whatever generic way you want to call this nebulizer. In your brief travel so far in clinicals, anybody seen treatments running? Is this what they've used?
No.
But you're probably going to see 9 times out of 10 in most places, because they're what? Cheap. They're very inexpensive. And I think I have one more. Which one is that? You can't see the one-way valves, but trust me, the one-way valves are there, but the big filter is kind of the giveaway. This is the Respigard. That administers what nebulized medication? I can't wait till pharmacology class because pronouncing some of these names is going to be so much fun. Pentamidine. Pentamidine is the medication that is going to be used in the Respigard nebulizer. Has the special one-way valves that you can't see in the picture, but the filter is always the dead giveaway. But we can actually make one of these. We have filters, we have one-way valves. You know the toughest part of this to put together or to find is that little Y split. You know where we steal it from? The ventilator circuits. The ventilators have that ventilator Y. Okay, I forgot I showed you guys the Y. The ventilator Y, you take the circuit off, and now you have the Y piece that's perfectly here. But that's, we end up tearing this whole circuit apart to steal just the Y. Alright, that was my last question. You guys have any questions for me? Anybody check this canvas still down?
It's still down.
Man, what's the matter with you, canvas? Well, I promise I'm going to bring your grades home with me. So I will have them. The second canvas, well, I won't know when canvas is unless I'm looking. But if anybody notices prior to 8 p.m. that canvas is up and open, don't wake me up. I'm watching Monday Night